Lowe's knows to bring your vision to life, it's important to find the right color. That's why MyLowe's Rewards members get a free Valspar paint or exterior stain sample to test your look to confidently refresh your space. Offer valid in-store only 8/7 to 8/20. Limit 1 per customer while supplies last. Discount taken in time of purchase. See associate for details. Rewards program subject to terms and conditions. Details at lowes.com/terms. Subject to change.
What's up, everybody? You are listening to the Strength and Knowledge Podcast. I'm Dr. Zach Baker, and with us today is Dr. Corrie Jones, who is going to dive a little bit into what got her into the profession of physical therapy. And I think, like all of us in the profession, we all have probably some similar traits, similar qualities and interests, but everybody's journey there is a little bit unique. And I've had the privilege of working with Corrie for a few years now. We went to PT school together. So I know in general why she's here, but I really want to unpack and kind of get the details of what got her initially interested in this, and then ultimately going all in head first into it. So Corrie, excited to hear your journey and what you've got going on. But yeah, let's start from the beginning. What even put the physical therapy profession on your radar?
Yeah. So a short, funny story first. I was really into animals when I was younger. And so I was actually really planning on being a wildlife veterinarian. And then in high school, at some point in time, they put us in these groups. I was part of a medical academy, and they put us in groups to go observe for the day and in different professions. So I went to hang out with a vet for a while, and then I went to hang out with at an SPCA. There was a lot of sad putting the animals to sleep and stuff that I couldn't handle. And then all the rest of it felt like it was a lot of bugs. It was mites and ticks and fleas and worms and gross stuff. I was so grossed out. So I decided after that I wasn't going to be a vet, and maybe people would have less bugs on them. And so I decided to
how's that working out for you?
Yeah, I think it's working out so far. But yeah, so I still wanted to be in medical field. I still wanted to help people. So kind of tossed around the different ideas, I was thinking about being an orthopedic surgeon or some version of that. But then it's interesting because I had a couple different injuries. My first big injury was a dislocated shoulder that I needed rehab for. And I had an amazing physical therapist. Her name is Laura Blair. She's just a sweetheart. She still practices nearby. And she was just phenomenal. And I got to know her. I got to spend 2 days a week with her. Whereas my orthopedic surgeon, also amazing, but I only talked to her 5 minutes at a time. I did not get to know her. And so I really liked the interactive part of physical therapy that I got to see with Laura. So decided that maybe as far as medicine goes, a job where I got to work out with people all day, be active all day, talk to people all day, and really get to encourage and build people up all day was the thing for me. So started getting interested in physical therapy at that point.
That's awesome. Now, I always wonder, and people ask me this a lot, if you didn't get into physical therapy for whatever reason, you don't get into school, or you just never crossed your path, or you're a PT and you're looking at a career change now, what else would you see yourself in? Are there any other comparable jobs, careers that are health, wellness, medical that you could see yourself in, or would it be a complete 180? And it would not be Corrie Jones, the health, wellness, medical professional, but you have some other hidden talents that we don't know about.
I was debating very heavily going to art school, actually.
I was not.
I love art. I love doing creative things. My high school art teacher was really pushing me to go to Pennsylvania, Philadelphia School of Art. And honestly, I still love it to this day. I have a little side business. And so, I think I would have pursued that and really invested in that. Back then all the social media stuff wasn't there. And so art, making your way as an artist is really hard. I think it's still hard, but it's gotten a little easier with the exposure rate and everything. But I think I would have 180'd. I think I would have been like a artist, and I think I would have done something very, very different than what I'm doing today. Maybe still teaching in some capacity, like maybe teaching art or something like that. But yeah, if I think about it, I think that's what I would have veered towards.
No, that's cool. And I've had the ability to see some of your artwork, and I can attest it is pretty amazing. Some of the stuff that you're able to do. It's a lot better than the stick figures that I put all over the clinic boards for my exercise demonstrations. Now, piggybacking off of that, because we'll get into more of the sports ortho side of things. If you were still in physical therapy, but you were not in the sports ortho world, where would you find yourself?
Yeah, my very first part-time rotation in physical therapy school was with Kennedy Krieger, and it was in the spinal cord facilities. So I learned a whole lot on the neuro side of things, and I absolutely loved it. I thought it was just like such a fascinating part of the profession, and you just got to impact people in different ways. And definitely a challenging setting, obviously, but still just such a really cool, rewarding setting when you see some changes that people go through and the ways they get back. So I still love neurology. I still teach courses on the neurology of sports medicine now. So like, I think that neurological system is just so fascinating to me. And then tied to that, I really love like the psych-soc side of physical therapy. So I guess all of that, though, is really, really tied to neurology. I once in a while throw around the idea of getting my board cert in that, but man, that was a lot of studying for the SES. So I don't think I'm up for it yet, but yeah, really think I would have landed in some kind of SCI or TBI, like neuro side of things otherwise.
That's cool. I never had any interest to do any of that. I honestly didn't even know that like existed until I was in PT school and they started telling me what we were going to be learning and what rotations I would be on. And I was like shocked. And that's not a discredit to the school, but just my own naivety and probably not doing enough homework to figure out what the PT world actually consisted of. But it's pretty cool. Like when you're in the hospital, when you're in the acute care settings, or you're in the neuro setting, whether it's acute or non-acute, I always just think like the stakes are so much higher. And, you know, it's fun working in sports and ortho, but, you know, I go home at the end of the day and it's like, you know, half of my caseload, it's like, all right, well, this person's 97% normal, but they have a little bit of Achilles discomfort when they're in mile 28 of their run. Like a very like first world problem that we're dealing with. Yeah. And then, you know, you think about when you're in some of the other environments, it's like, hey, we got this person to live independently. This individual is able to care for themselves, get out of bed, get onto their feet for the first time, and not have to worry about waiting on somebody else to do that for them. And I think that was an awesome experience for me, just seeing how rewarding that really was and getting able to play a role in that. I think it is equally as frustrating when you do every single thing that you can for that individual, and there's just some things that are out of your control. Or there's just some things that aren't clicking or aren't registering for reasons beyond what we can directly influence. And I think, you know, for as equally as rewarding of a setting that is within our field, it can be an equally frustrating one as well. And I think, not to say that different fields or settings don't have their own frustrations, but that was for me when I was trying to get into like, all right, what do I want to do? Sports, ortho, one of these other settings I didn't know existed. I didn't know if I would be able to deal with just like those interactions where you did not find success. And they would kind of stick around with me a little bit longer than somebody, you know, having knee pain with squatting or having Achilles discomfort when they're ramping up mileage for a competitive race. I'm like, I can handle that. I can triage that and navigate that and deal with the patient interactions there. The other stuff, I'm like, I'm not the best with words when it comes down to some of those situations. And I didn't think I'd be able to navigate those scenarios. But
I highly doubt that. You're a good talker. But
with kind of getting back to your injury experience and getting into the sports world, a lot of people get into sports PT because they've had an injury. And it's funny. They take two different paths, though. It's I had an injury. I had a phenomenal PT. I loved going to PT. They got me back to 110%, and I was better than I was beforehand, and I want to do that for somebody else. Or it's the opposite. They got into PT because they had an injury, and maybe things didn't go as planned. and maybe they didn't get back to what they wanted to, or maybe they got re-injured, or maybe they had a good experience. Then they go through PT school and realize, I didn't have a great experience. And I don't want that to be the case for everybody. Talk a little bit about your injury history. And I think you and I at R2P try to take the role of like most fragile, breakable person there is.
I think so.
But bring everybody up to speed on what your kind of injury history is, and which path did you take? Was it I had a great experience and I want to do that for others? Or was it now that I am in the field, I want to make sure people get at least a comparable, if not better, experience than what I had?
I would say I'm the mix of the two, which is, I guess, the best of both worlds. And maybe that's why I'm in this field still today, after, 14 years now. So my first, I had that shoulder dislocation I talked about earlier, and that was my first experience with PT in any way, shape, or form. And that went really well. And then not too long after, about 1 year later, I tore my first ACL. So that was just like a whole nother level, I would say, of physical therapy and understanding what it takes to get back to sport. I was a soccer player my entire life, so that's all I cared about. So I just wanted to get back to soccer so desperately. And again, I had the same physical therapist. She was great. We had a lot of fun. The science back then, I mean, that was so long ago. So the science and the field in general was so underdeveloped at that point. And I would say especially sports medicine, there's just no understanding and no overlap of some of what we know today. So definitely kind of fits a little bit of that category. Had a great experience, got back to sport, but could it have been better because of maybe some of the aches and pains I'm dealing with right now. But yeah, so I think some of that, yeah, definitely. I wanted to learn how to do that just in a more basically evidence-based way, and then just a way that just kind of is progressive with how the field has grown. But then lucky me, so my junior year of college, I was playing collegiate soccer and tore my other one. So I tore that ACL, had some meniscus involvement with that as well. And that was the opposite experience. I did not have, basically my school left it up to me as to whether I would go to PT off campus or whether I would rehab with my ATC. And the ATC had about, 500 students to deal with. She didn't have time for me. She had no programming for me. There was nothing set up for me. Basically, I winged it. I mean, like, there was absolutely no planning. Once in a while, she would give me like air squats to do. I mean, like, I basically did nothing for this ACL rehab whatsoever. And so it just kind of, that's like one of those when sometimes you can go to a college and just get lost in the numbers. Looking back, I should have gone to an external PT, but I didn't have a dependent way to get to that appointment very easily. And my schedule, being pre-med, pre-PT, was very packed. So it was just hard for me to kind of get off campus and spend that time. Same thing though, I at least got back to sport eventually. Took a little bit longer and had a lot more pain with that one. But obviously rehabbing yourself before you're ever in school, I had no clue what I was doing. And I'm blown away at like the functionality I got back, to be fair. So two experiences. The first ACL, really wonderful and helpful. The second ACL, just really wanting. But in the long run, just kind of showed me both examples and showed me that there can just be a better way of doing things. And I just wanted to be the PT that not only was there and present and awesome like Laura was, but then also just somebody that had that that has done the research and stayed up with the current times and understands programming, understands strength and conditioning principles, so that I could be really, really solid as far as being good for my patients. So a little bit of the both end of what you described.
It's always interesting when you have an injury like an ACL and the variety of different scenarios that can take place. And you can go to outpatient PT. If you're a collegiate athlete, you can handle it in-house. What that looks like is drastically different if you're at a Power 5 Division I school that may have PTs, ATs, strength coaches, massage therapists, nutritionists, sports psych, and they have that for every single team. Or you may be at a smaller school that has 4 athletic trainers for 1,000 different student athletes. And yes, postoperative rehab is something that they are capable of doing, and it can fit into their day. But so is getting the 75 football players to practice on time. So is getting the 60 men's lacrosse players to practice on time, the 30 women's soccer players, the 150 track and field athletes. And you start to realize that there are different struggles and different challenges that the professions face when trying to develop a perfect rehab program for somebody. No different than when you go to an outpatient clinic and that PT may be juggling 2 or 3 patients at a time, or they have something that they want to do with you, but insurance isn't allowing it, or they're not providing that benefit. So they got to find another way to get you that resource or get you access to that intervention. So,
or even the space if they don't have the space for something.
Yeah. I remember the first clinic I worked at. I remember rearranging where equipment was to be able to do cone drills with somebody. And I was physically moving a treadmill out of the way to create another 4 feet of space to do something. And it was just, it wasn't the owner's fault. It wasn't the PT company's fault. It was just when they moved into that space, they had built it out a certain way, and then they had kind of outgrown it. And we were just in that awkward phase of where they had outgrown the demand that they already had with their patients. So it's always interesting. And I look back, I've had 2 ACL tears. Both were in high school, one junior year, one senior year. So I did one exclusively at an outpatient clinic at home. And then I did the other one for like the first month at home until I left for college. And I did the rest of it in the athletic training room at the college. And luckily, they were a very well-staffed AT department. They also had a significant number of students because they had their own AT major there. But again, it was a drastically different experience, and not really for better or worse. There's things that I liked about each location, and there was things that, looking back on it, I'm like, that probably left a little bit to be desired. And then also the realization that was 20 years ago. And a lot's changed in 20 years. And what was what was standard operating procedure then and acceptable then, we look at that now as like, we know a lot more. And there's certain things that should be added, and there's things that should be supplemented to that. When you were going through PT school, so at this point, you already had a general idea of what you wanted to be when you were growing up. That kind of got narrowed down once you realized you didn't want to work with ticks and mites and bugs and everything else, and you decided you wanted to work with humans. Then you, being a human and being an injured human, went through the PT realm yourself, and now you find yourself in PT school. What were some different things on your clinical rotations that you did that really either solidified like I want to go sports ortho, or it really helped frame up your approach as to how you wanted to treat patients, or just the type of environment that you wanted to find yourself working in?
Oh, this is a good one because I feel like I had very specific things that I learned in each place I went. So my very first clinical was out in Southern California, in Marietta actually. And out there, I was at a sports ortho clinic, and a couple of different things I learned there. Number one, we were able to cover the high school football team on Friday nights. So it was like us, another PT and ATC, and then the ATC for the high school. And then some of the doctors came along with us as well. And that experience was just awesome because it just brought us right there on the field. We were part of the medical team taking care of athletes. And that was so cool to me. And I really appreciated that opportunity because we would see them and see the play they got injured in or whatever on Friday night. And then that way we could follow up with the ATC. And then that way we could follow up with the doc. And everything was so easy communication wise amongst that team because we all worked together and we were there together. So that really made me want to be a part of the sports med team because of that interplay with profession. And that was just a really cool experience there. We saw a lot of motocross athletes as well at that place. So that just being sports oriented, that place opened my eyes to the different opportunities just in sports medicine. My next rotation was in Fairbanks, Alaska, and that was my acute care rotation. And I feel like what I learned up there, I was at Fairbanks Memorial Hospital, and my clinical instructor there, Jennifer Osnes, shout out, she was just the sweetest human being I've ever met in my life. And no matter who was in front of us, she was calm, cool, and collected. And she just presented herself in a way that, like, for each of her patients, they knew that they could trust her. She was going to be there for them and help them through like a really hard time because they were in the hospital. I don't think I learned how to be calm from her because that's not my personality. But hopefully I learned just kind of taking care of the person in front of me and like really trying to build trust. Then I was in Washington. I was in Olympia, Washington, and I was just at kind of like a nursing home facility. In kind of like a transitional care unit. And my instructor there, he was the best person I've ever heard physical therapy wise. Maybe, you might be up there, Zach. You do a good job with this too. But he was so good at communicating with patients and like explaining what was going on with them. A very clear way of communicating. He could break down a very complex, like we had a couple patients that had spinal fusions. And he could sit them, at the edge of the bed and show them. He used pictures, which I still encourage my students to do today, like show videos and show pictures, get your patients to understand the things that you're talking about. We would print out anatomy for them to understand what was happening. And we would take time in education. And I don't think in school or any of my other clinicals did I emphasize education as much as he did. And so I felt like that was like the main thing I learned from Bill. And really same thing, have kind of carried over today, really emphasizing education for my patients. And then my last rotation was in Boston, and I don't know, I feel like the main thing I learned there is just befriending patients so that you earn that kind of like collaborative type of rehab, because my CI there was hilarious. And she was just a talker. She was a yapper, and she could communicate well with people. And I think she just taught me that. So little pieces to take away from each section of my clinicals. But I would say the interesting thing there is that was my first job. So my last rotation is where I took my first job in Boston, and they did not have a lot going. They had some sports, patients there, but they didn't have a lot. So basically what we did was develop programs and screens and stuff that would get us out into the community to start reaching out to athletes to bring them into clinic. So we started working with ATCs, working with the high schools. I started doing like FMS screens were big back then. We were doing all this stuff to bring athletes to the clinic to start working with them. So I think that kind of got reinforced there a little bit too. So basically just like having the background of sports and all this stuff. And then those two clinicals were huge for me, and just saying like, hey, I really, really think sports is the answer. And then kept in, in communication with some of my classmates that were feeling the same thing. To be fair, Josh and I, so our owner, communicated kind of throughout our clinicals too, chatting through some sports rehab stuff. And that was helpful when you find like-minded people within your class and within other PTs, just talking through some of the difficulties or some of the challenges or some of the things that we found interesting in sports medicine. That kind of helped fan the flame a little bit too, to say like, yeah, I think out of all the things I've seen, I really, really want to dive into working with athletes. Because I really wasn't sure for a while, but yeah, I would say some of that is what really clarified that for me.
That's cool. I like how you mentioned the different things from your clinical rotations that you took away, and none of it had to do with like a groundbreaking test that you learned or some cool exercise. It was, I learned how to talk to people. I learned how to educate them on what was going on and how we fit into that puzzle with them of getting them back to where they wanted to be, and getting them to trust us and letting them know that, hey, we're under control. We're calm, cool, and collected. We know what we're going to do. And if you don't do those three things, it doesn't really matter what you know or how you execute your interventions, because the people aren't going to come back, or they're not going to buy into it, and you're going to get 50% effort on everything. And I remember one of our professors at Maryland, he had mentioned in the opening weekend when we did like our ropes course as kind of like our icebreaker with everyone, He had kind of told the story of how he was a borderline C student who almost failed out. And he is now a professor at the school, and he was not the most intelligent person from a book smart standpoint, but he was one of the most resourceful. And when he realized he wasn't doing well, he sought out a tutor. He talked with his professors. He had other classmates help get a study plan. And he made his way through school, and now he's a very respected PT in the greater Baltimore area, especially throughout the hospital system. It was kind of his reminder of like, hey, we all have strengths and weaknesses, and we're not all going to be the smartest person in here. We're not all going to get perfect scores on everything, but we all have something that we can contribute and something positive. And if we work together as a team, we can leverage each other's ability. And I think that's really, when you get into the sports medicine field, it is a team effort. Obviously, the patient is the focal point of that team. You have a physical therapist that's driving a lot of the rehab plan of care and the execution of the rehab plan of care. You may have athletic trainers that are, if the person has one as part of the team that they're on, that's going to be involved with it. You have whatever physician is overseeing it, whether it's a non-operative or an operative case. But now that you have been in the field for 14 years and you've been in a variety of multidisciplinary or interdisciplinary teams, or at least communications, what has been something that has really grown on you or grown with you in regards to an optimal plan of care and patient outcomes when you're dealing with an interdisciplinary unit? What are things that you feel younger PTs or students in PT school should really be aware of in order to drive good patient outcomes and a good patient experience when you're working as part of a care team?
That's a good question. I would say one of the things I would dive into there is communication, obviously. So making sure that everyone is on the same page. An example of that. So I work at Hood now with R2P, and we share a document with the ATCs and the strength coaches to allow them to see hey, here's where this person is in their rehab status. Here's what they should and can and could be doing in the lifting area with S&C. And then as far as ATC goes, they're the ones that kind of are almost act like primary care, where they kind of direct care back and forth between everybody. And so I think communication is the number one thing. So if you can respectfully work together with others, that's probably the biggest thing, just working on those soft skills. How do I communicate what I'm really seeing with this patient to other people? Communication would be the number one thing that would really make that successful. And that's even in regular outpatient too, right? Because you have to communicate with the parents or with sports coaches or with other PTs that are helping treat your patient. So communication goes a long way. And then I would also say, if we're talking about what really makes that team successful, is not making everything about opinion, right? So if I can use objective measures to actually show what I'm seeing and explain why I'm drawing the conclusions that I'm drawing based on the numbers and based on the test, that goes a long way too, because it's not just oh, I think they're ready for this, or I want them to start trying this or whatever. It's just a little bit more objective, so that communication is understood in a way that everybody can see, which phase of rehab they're in. They can see why I'm making these clinical decisions, rather than just guesstimations. So communication, objective measures, the ability to communicate those objective measures. And then, maybe just, as you said, making sure that a plan of care is carried out. I think it's just getting buy-in from the whole team as well. So being really excellent at explaining what rehab is. Can you explain the process well? Can you explain why certain exercises are needed? Can you explain why certain mobility is needed? I think just having the ability to explain the profession, what do we do as rehab, professionals, the better we can explain it, the easier it is to get buy-in from not only the patient, but anybody working with the patient too, to say, this is why I'm making these decisions, and this is why I'm presenting the patient with these treatments. I think if you can educate people on the process, there's a lot less unpredictability, and they have a better, group of expectations to have, because all of us know most of our frustrations, disappointments, all of these things in life and in PT come from expectations that either weren't clear or were inappropriate, right? So taking the time to be able to really lay those things out would be helpful too. So I don't know if that fully answers your question, but those are the things that come to mind with really helping somebody finish a plan of care, especially in a team sort of setting.
No, that's great. You had mentioned expectations and setting expectations through proper communication as being paramount. And two different stories kind of highlight that for me. I was doing a clinical rotation out in Phoenix, Arizona, and they had ATs on staff out there. So they had PTs and ATs that worked in the clinic together. And I was towards the end of my rotation, so my CI wanted me to communicate with the AT about a patient update. And I went over and I was talking to Mike, and I was literally just like rattling off the note that I just wrote. He stopped me like halfway through after me rambling for 2 minutes. And he was like, Zach, I'm capable of reading. Like, tell me two things. Either tell me something I can't read or tell me something the patient can't articulate. Anything else I can get from the note. But he's like, if we're ever communicating, assume that I've read the notes and just tell me whatever isn't in the note, or tell me something that the patient wants me to know, but they can't figure out how to say it. And that was very it was sobering for me, because like, all right, now I've got some guardrails in regards to what I do and don't need to tell people. And then I had another physician who we see a lot of patients from. And I was like, I don't know what they want to know from us when we're sending patients back. And I feel stupid just sending patients back and not having the patient relay anything regarding PT. But I also appreciate that this is probably one of like 50 people on that physician's schedule, and they don't have time to read a 4-paragraph note saying the patient's doing well. So I asked one of the physicians, like, what do you actually need from me? Just so you know that I'm actually involved in the process, but I don't want to just burden you with reading notes. And he was like, Zach, I don't need a post-operative patient coming back 2 months post-op, walking in normal, demonstrating full range of motion, and then you giving me a note that says they have full range of motion and they're pain-free. They're like, I can tell that. I expect that. I know that that's happening. So I don't need to know if they have 127 or 124 degrees of knee flexion. I can clearly see they're doing well. Like, what I want you to communicate to me is if there's anything out of the ordinary happening, or if you need clarity on what to do moving forward that isn't expressed in the protocol. And then other than that, we can both operate, me from a PT standpoint, knowing I can do whatever is in the protocol and I don't need to ask for permission. And the physician can know when this patient's coming back to me from rehab to perform, everything is going as planned unless Zach is telling me otherwise. And that was really helpful because it saved me a lot of like scrambling throughout the day, trying to create all these random case notes that just weren't going to be acted on because there's no meaningful information. But it also helped me understand, like, hey, if I've got to send 2 or 3 sentences to this physician, what is it that they actually want to know, need to know, or would be helpful? So, Corrie, as we wrap up here, any other final kind of words of wisdom or parting tips from your journey into the PT field that we haven't gone over?
I think the biggest thing is just making sure that, choosing any profession, but I would say specifically for PT, for me, it's been how can you help people and how can you support people? One of the first things I start out talking about in my mentorship, course that I wrote is make sure that if you want to go into PT, you like people. We're dealing with people all day long. And honestly, I think the best part of our job is that you really do form relationships. Like, people know you. If you're hanging out twice a week, like, how many of your friends do you hang out with twice a week for an hour at a time? It's kind of cool because you really do have time to converse with people, get to know them, get to know their lives. And you have this really unique opportunity to encourage people and motivate them and push them towards this better life situation. Josh talks a lot about the future of healthcare. And honestly, all of us want to get to the point where PT is a little bit more on the preventative side than just only rehab. But the cool thing is that so many times in sports medicine, I have a patient that comes in because of pain, but they leave and they're like gym rats, or they're interested in lifting and they're interested in taking care of their health. We've had conversations about nutrition and sleep and strength training and endurance training. And I think just the conversations towards and around health are really exciting to me, and honestly encourage me to try to, hey, like if I've been struggling with aches and pains I still have from those injuries we talked about earlier, like get back in the gym and keep working hard and stick with that nutrition. And I think there's just this cool give and take that if I encourage, if I spend my days encouraging people, there's something to be grateful for about that, because there's some jobs that I think it might be a little harder to identify how you're giving back to the community or how you're paying it forward or stuff like that, where I feel like with our profession, I feel a little spoiled because it's just every day. That's what you're doing. You're giving back, you're paying it forward. You're trying to help other people live their best life. And it sounds like a little bit soapboxy, but that's I feel like the cool thing about our profession. So feel a little, I'm grateful and thankful for the job and for the profession. So yeah, that's, I guess, my last 2 cents as far as anybody looking into physical therapy. So
awesome. Well, Corrie, thank you for sharing your journey. If you have listened to this and you've enjoyed it, please share, like, and subscribe. You are listening to the Strength and Knowledge Podcast. Stay tuned for next episode.